Welcome, everybody. So this is the I-STARR webinar series, and I-STARR stands for Infrastructure for Studying Treatment in Addiction Recovery Residences. And the I-STARR project aims to develop infrastructure to advance science on recovery housing, particularly for those who are receiving medications for the treatment of opioid use disorder. And today we'll be hearing from Dr. Cindy Nichols, who will be presenting findings from a study examining factors affecting implementation of medications for opioid use disorder in recovery residences. Now, if you haven't been to one of these webinars before, you'll know that the I-STARR project is supported by a grant from the National Institute on Drug Abuse, and it's also part of the larger NIH Helping to End Addiction Long-Term, or HEAL initiative. It's also one of several projects that comprise the Consortium on Addiction Recovery Sciences, or the COARS network. So just some quick housekeeping notes about the format of the webinar. So all audience members should be currently muted, and we encourage all attendees to use the Zoom chat function to introduce themselves, connect with fellow audience members, and ask questions of our presenter. And we do have an I-STARR project team member monitoring the chat, and we'll unmute audience members after we hear from our presenter so that attendees can raise your virtual hands and participate in a discussion at that point. So we're just going to hold questions till the end. Also, the webinar and each webinar in this series is being recorded so that those who are unable to attend today will be able to learn from it. And then finally, as a reminder, there is closed captioning of this webinar, which is available within Zoom, and you can find it using the functions at the bottom of the screen. Next slide, please.
Writing his name out on the signature.
So I am Carmen Masson. I'm a faculty member at the University of California, San Francisco, Department of Psychiatry and Behavioral Sciences. And the I-STARR project is led by Drs. Amy Miracle and me. Dr. Miracle is at the Public Health Institute. And the team also includes co-investigators Sarah Zimor and Lenny Jason. Everybody needs to mute themselves, please. And the team also includes co-investigators Sarah Zimor and Lenny Jason, and biostatisticians Mina Subbaraman and Libo Lee, and our communications specialist Diane Schmidt, and the team's project coordinator Quinoja Capitani. Next slide, please. So we are also very blessed to be working with an amazing advisory board. It's a 17-member advisory board, and they are diverse leaders from across the country, and the areas of their expertise are recovery and recovery housing leaders. They're treatment providers and payers. They represent they're national policy advocates, and they're also researchers and educators. Next slide, please. So it's my pleasure to introduce to you Dr. Cindy Nichols. She's a senior project coordinator at the Child Health and Development Institute in Connecticut, where she works on substance use initiatives aimed at expanding screening and services for youth with co-occurring disorders. Her research focuses on implementation science and substance use, with a particular attention to the implementation of medications for opioid use disorder in recovery residences. She's published and presented on topics including the use of buprenorphine in non-hospital residential treatment settings, ethical considerations in substance use treatment, prenatal substance use exposure, and child welfare involvement, and family treatment courts. So without further delay, let's turn the presentation over to Dr. Cindy Nichols. Thank you.
Thank you so much, Carmen. All right. So thanks, everyone. Thanks so much for coming today. Thanks for having me. So today, I'm going to be talking to you about my dissertation findings, and this was titled Contextual Factors Impacting the Use of Medications for Opioid Use Disorder in Recovery Residences. Just a little bit about me. So I'm an LCSW, I'm an LADC. I started my clinical work in Boston, where I worked for several years in substance use settings, all of which prescribed medications for opioid use disorders. And I initially worked at a methadone program after completing my MSW. And these pictures show the area where I worked in. It was called a very stigmatizing name called Methadone Mile. And it still remains a very stigmatized area to this day, where many of those that are receiving treatment are also unhoused and forced to live in encampments due to the limited support service options. So, for my dissertation, I really wanted to address the need for support services, specifically transitional housing, needed in a person's recovery. And as mentioned, I conducted this work under my PhD program, which I finished a little over a year ago, and now I work at CHDI in Connecticut, working on the co-occurring disorder initiatives and implementation science. And I want to give a special thanks to all those that really helped with my dissertation, NAR, and all the recovery residence leaders who took this survey, and of course, Dr. Amy Miracle, who was on my committee. I also want to acknowledge that my work was funded by NIDA as part of the BST fellowship that I was under, sponsored by NYU. So I just wanted to make note of a few key terms and acronyms I'm going to be using today, just listed here. So our R's are going to be in the slide for recovery residences, Oxford House, OH, MOUD, NAR, and then the Consolidated Framework for Implementation Research, or CFIR. So my agenda, I'm going to start with my background and rationale. I'll get into the theoretical framework, my three papers for my dissertation, and then conclusions, implications, and then we'll get to all of your questions. So I'm not going to go into too much detail. I think this is all things that you all know, but MOUD is one of the most effective treatments for individuals with OUD. It's significantly improving retention and treatment while also reducing mortality and substance use. There are different forms of MOUD that have different mechanisms of action. This really matters because literature has suggested there is greater risk of diversion for recreational use of agonist and partial agonist MOUD, such as methadone and buprenorphine products, which often contributes to preferences for agonist and long-acting injectable or extended release MOUD types. And this includes like Vivitrol and Sublocade, medications like that. And then MOUD can be used indefinitely. It's often most effective when used in conjunction with behavioral interventions, such as residential services. So, what are the specific needs of those using MOUD? For those with opioid use disorders who access treatment, they're most at risk of relapsing following short-term inpatient treatment immediately after they're started on MOUD and immediately after they discontinue MOUD. So long-term recovery support services are really essential to maintaining a person's recovery. And an important example of this are recovery residences, as ours meet several needs for individuals exiting treatment, including an alcohol and drug-free environment, stable housing, peer support, and access to recovery resources. So integration of MOUD and RRs, historically, many have been abstinence-based and prohibited the use of any psychoactive substance, including MOUD. NAR has released a guide for how to support those using MOUD, but there still is limited research, as we know, about this. And literature hints at several barriers to integration, including ideological, funding, and then cultural factors. So given that there are several identified yet under-researched variables associated with MOUD integration in recovery residences, a framework is really needed to understand both the barriers and facilitators or pathways to supporting those using MOUD. So that's sort of what my dissertation was all about, was identifying this framework and using this framework. And you might have noticed that I've been using the term integration thus far in this presentation, and in thinking about a framework, the nearest conceptual neighbor to integration that also provides both theory and empirical literature on factors associated with adoption is implementation. So one of the most current and used frameworks for understanding implementation is the Consolidated Framework for Implementation Research, or the CFIR, which has often been used when assessing implementation, mostly in clinical settings. So the CFIR is quite large. It organizes 26 constructs and 9 subconstructs impacting implementation in 5 domains that are shown here on this pie chart. So those are intervention characteristics, outer setting, inner setting, characteristics of the individual, and then the implementation process. And according to recent literature about this framework, each construct must be present in sufficient balance, meaning duration of effect, and strength, meaning magnitude of effect for the setting to successfully implement an intervention. And I just want to add there is an updated CFIR, CFIR 2.0, that has been published. I used the original CFIR because the survey instrument that I adapted was from a previously validated study grounded in the original CFIR domains. And at the time of this development, when I conducted my dissertation, the updated CFIR was really still very new and it had limited sort of empirical application in survey-based measurement. And additionally, the original CFIR, as I'll talk about, the constructs were aligned more closely sort of with my studies focus. So that pie chart was it's a little overwhelming seeing all these different constructs. So here's a more simplified version of the CFIR describing how this can relate to recovery residences. So intervention characteristics might be related to recovery residence owners and managers' perceptions about MOUD as an intervention. So basically, this means is MOUD, does it seem doable? Is it overly complex? Is it costly? Is it better than an existing intervention? In terms of outer setting, this is related to the economic, political, and social context surrounding a recovery residence. So a common example of that might be funding provided. For inner setting, this pertains to the recovery residence culture, climate, and then readiness to implement MOUD. Characteristics of the individual pertain to the frontline workers, or in this case, recovery residence managers or owners, motivation to implement the use of the intervention, so MOUD. And then the last one, process. This is really the planning process of implementation efforts of MOUD in recovery residences. Okay, so the CFIR was used to guide the 3 papers of my dissertation shown here. The first was a conceptual paper talking about the CFIR, and then the second 2 are data-driven articles using findings from the survey. So first I'll talk about paper 1. This was titled Implementation of a MOUD in RRs, Theoretical Framework and Future Directions for Research. So the objective of this first paper was to apply the CFIR framework, to first organize existing literature on the use of MOUD in recovery residences, to gain a clear understanding of the facilitators and barriers to its implementation, and then also develop a research trajectory. So for paper 1, literature searches were conducted in the databases listed here. Permutations of the terms listed here were also used. Studies were reviewed using the following criteria. So they first had to assess the use of MOUD in RRs, and then they had to be published in the past 15 years to include recent studies. And then lastly, studies were aligned with CFIR concepts. Any CFIR construct with relevant empirical support were characterized by strength of effect and valence. So at the time of this literature review, so this was a little bit ago, I found 5 studies that met this criteria. For the sake of time, I won't be reviewing these in detail, but I want to discuss how these studies relate to CFIR domains and constructs, as well as whether there was a positive or negative relationship indicated. So one study found MOUD characteristics related to the need that for pill counts in this particular residence made the intervention more complex and presumably contributed to this negative effect of successful implementation of MOUD in recovery residences. When thinking about outer setting factors, specifically policies and incentives, one study showed a positive effect, finding that houses with funding and NAR certification accepted at least one type of MOUD. And then for this slide, I combine inner setting and individual characteristic domains, since these studies that I looked at weren't designed to measure these domains and constructs separately. and findings could reflect either one of these intersetting or individual factors. So when thinking about both these constructs, negative recovery residence culture and beliefs towards MOUD was discussed in all 5 studies, contributing to a negative effect on implementation. So 3 of these studies showed there to be negative attitudes about MOUD and types of MOUD among recovery residents in certain states, while 2 other studies found residents often encounter discrimination when accessing recovery residences due to their MOUD use. And then conversely, 2 studies found a more positive culture and beliefs towards MOUD to ultimately have a more positive effect where residents felt more comfortable in these settings. So overall, with this review, I found that MOUD characteristics and negative RR culture towards MOUD were found to serve as barriers to implementation. Conversely, RRs with a positive culture towards MOUD, as well as external funding and NAR certification, were found to serve as facilitators. One study found MOUD preferences existed among RRs, specifically that methadone was the least accepted medication and tapering was encouraged, while the use of buprenorphine and naltrexone was not associated with encouragement to taper. And then some of these studies also only took place in certain states and among certain types of recovery residences, specifically Oxford houses. And while no studies pointed to valence, so that negative or positive, while studies pointed to valence, so the negative or positive relationships, no studies documented strength of effects. So overall, further research is warranted to discern which CFIR domains and constructs are most strongly associated with successful implementation of MOUD. And then I also wanted to talk quickly about potential directions for future research. So where do we go from here? So I've discussed a research agenda divided by the 5 CFIR domains. So first, starting with intervention characteristics. Prior research highlights concerns about MOUD as an intervention, including logistics related to increased costs and added complexity. So future research should really examine whether MOUD adoption is associated with operational costs. There's also a need to evaluate the impact of targeted educational trainings on MOUD knowledge and attitudes. And then future work should explore how variation in recovery definitions across residences influences perceptions of MOUD effectiveness. And additional research is also needed on the perceived adaptability of different MOUD types, including concerns about diversion risk with certain types. And then in thinking about outer setting, we've seen that certification, connection to NAR, and grant funding can serve as facilitators to implementation. So research should really prioritize assessing the relationship between RR certifications, NAR affiliation, and then outside funding, including replicating these previous studies conducted in specific states, and also understanding if NAR affiliation, MOUD acceptance is required in all states to receive funding. And then in regards to intersetting and individual factor domains, we know that a lack of buy-in and negative attitudes can really be a barrier to implementation across anything. So we need to think about how to assess motivation to implement MOUD among staff, as well as their attitudes about changes. This may include investigating stages of change experienced by house operators during the implementation process, and better understanding perceived challenges in implementation efforts. And then lastly, in regards to the process domain, so there's virtually no research about this domain in regards to MOUD implementation in RR. So based on other implementation studies and from what I know about implementation, we know that the planning process is really important. And obviously things go wrong and you can't prepare for everything. But future research should look at what process efforts are in place for recovery residences, what leaders are involved, and whether evaluations are conducted. So overall, from this first paper, there were 3 major implications I came away with that guided my next 2 papers. The first was attitudes related to ideology and concerns over logistics of MOUD impacted implementation. The second was that preferences for certain types of MOUD exist. And then lastly, very few of the CFIR constructs were addressed when discussing implementation of MOUD and recovery residences. And this framework can be used to identify other barriers and facilitators to implementation. So moving forward, moving to my two papers, paper 2 and 3, I just want to explain that um, also that these papers came from one study with the same survey. And the methods for paper 2 and 3 were the same with some changes to the independent variables that I'll discuss shortly. So starting with paper 2, this was titled Influence of Attitudes on Recovery Residences Acceptance and Use of MOUD. Starting with my research question. So this second paper really focused on the domain of the characteristics of the individual, specifically attitudes towards the use of MOUD. So my first research question was, do RR leaders have preferences regarding MOUD types? And I predicted some leaders would prefer antagonist and long-acting injectable MOUD types or extended release types. And then do RR leaders' attitudes related to both ideological and logistical challenges about MOUD impact implementation? And I predicted I predicted RR leaders with more positive ideological and logistical attitudes about MOUD would accept more types of MOUD and would have greater extent of use across residents compared to those with negative attitudes. So to answer these research questions, I decided to conduct a survey using to just get a broad overview for many different types of leaders, given that we have very few studies about this, and just to start to build the literature. So this survey instrument combined existing CFIR survey items assessing implementation from a previous study from Kegler and colleagues in 2018. This was related to a different type of implementation, not related to MOUD. And then some questions were specific to MOUD use in RRs that were written by myself. And then participants who reported accepting MOUD were asked additional questions about details related to acceptance. And the survey was reviewed and revised in consultation with a community advisory board consisting of 4 recovery residence house owners in one state. And then the survey was disseminated via Qualtrics. So my sample was our owners, managers, and operators in 20 states in the US. So a convenience sample was used for this study due to there being no existing national database of recovery residences with contact information. And participants were recruited from October of 2023 through April 2024. My inclusion criteria were they had to be 18 years of age and they had to be working or overseeing a recovery residence for at least 1 year so that they understood enough about the setting where they were working. And they need to be English speaking. Contact information for eligible participants was requested from NAR and other NAR state affiliates. Non-certified RRs were identified through online searches in selected states that had publicly available contact information that I had found. So starting with my dependent variables. So the first was total number of MOUD types accepted, and the second was extent of MOUD use among residents. So this reflects 2 dimensions of implementation. The first is adoption, so whether they actually accepted MOUD, and the second is penetration or reach, actual use. So I really wanted to highlight just not that residences were accepting, but is it actually being implemented? Are residents actually using MOUD in residences? So total number accepted was calculated by summing the total number of MOUD types that participants reported accepting from a list of 6 medications that are shown here. I included different types of MOUD with different mechanisms of action. And then for the second dependent variable, participants were also asked how many residents in their RR used each of the 6 types of MOUD over the past 12 months, over the past year. And answer choices were on a Likert scale, so 0 being none use this type, to 4 meaning all use this type for each of the 6 types. An extent of MOUD use among residents was calculated by summing participants' responses to how many residents use different types of MOUD. And yeah. Okay. So moving to my independent variables. So as noted previously, literature points to 2 dimensions of attitudes about MOUD and RR that may operate separately. So for the second paper, my 2 independent variables were attitudes about MOUD from a logistical perspective and also an ideological perspective. Ideological attitudes were measured with 7 items using a Likert scale from 1 to 5. So, 1 meant significantly decreases whatever outcome I was asking about, to 5 means significantly increases whatever outcome I was asking about. And then questions asked about items listed here. So, perception of MOUD and impacting a person's recovery, employment, relapse, treatment retention, risky behavior, overdose likelihood, and then recovery residence values. And then an ideological attitude scale was created by taking, oh, sorry, So the ideological scale was created by taking the average of these 7 ideology questions. For the second independent variable, logistical attitudes, this was measured with 7 items using a Likert scale from 1 to 5. Again, 1 meant significantly decreases whatever outcome I was asking about. 5 meant significantly increases whatever outcome I was asking about. So the outcomes were about perceptions of MOUD impacting triggers, medication reliance, emergencies, external recovery support, medication misuse, funding, and staff. And then a logistical attitudes challenges attitude scale was created, taking the average of 5 of these 7 items. This was due to an exploratory factor analysis, which I'll discuss more shortly, but 2 items were dropped, so I only ended up using 5 of these. And then moving to my control variables. So several variables conceptually associated with the outcome of interest were included as controls. That included participants' time in their role, the RR level, the proportion of non-white residents in the RR, number of beds in the RR, whether RR accepts females, and then the state. And then lastly, I had a descriptive variable asking participants if they preferred certain types of MOUD, and if so, which types. I use similar analytic tools for both the second and third paper, including survey psychometrics, descriptive characteristics, and then Poisson and OLS regressions. State fixed effects were included to account for variability and clustering in the state level in the regression models, but I didn't show these in the tables. Or in my presentation here today. So in terms of descriptive statistics, the sample, approximately 58% of those who took the survey were house managers or operators, 42% were house owners, 64% had both direct service and administrative duties, 31% had spent less than 2 years in their role, with only 13% being in their role for more than 10 years. 53% were monitored level 2 houses. Houses reported serving a greater proportion of white residents compared to non-white residents. Most houses accepted female residents, 65%, and fewer accepting male residents at 55%. Less than a quarter of houses accepted gender diverse residents, 19%, and then 74% reported being sober houses compared to another type of house like an Oxford house or a halfway house. So in regard to MOUD acceptance and preferences, 92%, so pretty much all, reported accepting MOUD, and a little under half of participants reported preferring certain types of MOUD. So the blue bar of this graph shows the percentage of what all of the participants reported accepting, while the orange bar shows the percentage of what types of MOUD are preferred among the 46% that reported preferences. So the most accepted type of MOUD among houses was Vivitrol. This was at 80%, followed by oral naltrexone at 83%, then Sublocade at 77%, Suboxone at 77%, and Subutex at 71%. The least accepted medication was methadone at 68%. And then in regard to preferences, the least preferred type of MOUD was methadone, with 0% preferring this, and Subutex 6%. And then Sublocade at 25% and Vivitrol at 36% were reported to be the most preferred. And just as a reminder, these are extended release types that usually require a once per month injection. So this slide shows descriptives of the two dependent variable scales, the total number of MOUD types accepted, and then the extent of MOUD use. So overall, homes accepted on average between 4 to 5 types of MOUD, which is pretty high. And as discussed on the previous slide, you can see here that Vivitrol was the most accepted MOUD type, methadone was the least. And then among the extent of use scale, the most used MOUD type among residents over the past 12 months was Suboxone with a value of 1.90. So this meant that they were answered this as reporting that on average, some residents used this type. And then the second most used was Vivitrol, meaning that on average, participants reported a few used this type. And then methadone was the least used medication over the past 12 months. They reported none to a few were using this medication. And so then I want to show the ideological and logistical challenges scales with the alpha scores. So because these scales were developed for this study, validity was assessed using exploratory factor analysis to examine the dimensionality of the items. So for the ideological attitude scale, a one-factor solution explained the largest percentage of variance. All questions demonstrated factor loadings of above 0.64 and were included in the scale. So the final scale included all 7 items. And then for the logistical challenges attitude scale, a one-factor solution was also explained a largest percentage of variance. However, 2 questions on the scale demonstrated lower than acceptable factor loadings. So these were dropped. And these were questions related to medication reliance and funding. This could have been related to an issue with the scale, or maybe that they needed to be just standalone items due to the questions potentially maybe tapping into more than one factor. But the EFA was repeated with these 5 items, and it demonstrated strong internal reliability. And then I just want to point out here that findings indicated lower averages on logistical challenges items. And this suggests that there is concern related to logistics of implementation of MOUD. So you can see here on the blue chart, the lowest average was staff. So this suggests that there may be challenges related to not having the necessary staff in supporting implementation, which is a very valid and concerning logistical item. And so this graph now presents findings from the Poisson regression assessing the association of leaders' attitudes and total number of medications accepted. So the ideological attitude score was significant. You can see that here in green. Every 1 point increase on this attitude scale was associated with a 28% increased rate of total number of medications accepted when controlling for other covariates. So this indicates that leaders that score higher on this ideological attitude scale are expected to accept more types of MOUD. And then from the next table, this presents findings from the OLS regression assessing the association between leaders' attitudes and extent of MOUDs among residents. So beta values are shown here in order to compare across variables and better understand the magnitude of effect. MOUD ideological and attitude score was significant. So again, with a beta value, 1 standard deviation increase in the MOUD ideological attitude scales was associated with a 30% standard deviation increase in extent of use. So my results indicate that while the majority of participants reported accepting MOUD in their houses, preferences existed among close to half of the participants, specifically for the use of extended release types of MOUD. Vivitrol and Sublocade were those types. And these results are similar to previous research, indicating that there are preferences for buprenorphine and naltrexone over methadone. And this might often be related to concerns of diversion. And then also Vivitrol and Sublocade types are potentially preferred due to these types, as I mentioned, requiring a once per month injection. And they don't often, I mean, if you're getting a once a month injection, it doesn't require these medications to be dispensed or brought into the houses. But overall, these preferences are concerning as availability of Sublocade really remains limited across the US, while methadone and Suboxone are two of the most commonly accepted or commonly used and accessible types of MOUD. Secondly, my findings adds to the notion that positive ideology towards MOUD can increase the number of MOUD types accepted and use among residents. Overall, this suggests perceptions of MOUD being viewed positively as an effective intervention can increase two dimensions of implementation. And then lastly, despite attitudes about logistics not being significantly associated with acceptance or extent of use, participants' scores on these logistical attitude items suggest that they have potential concerns, and the implications of these concerns is still unclear. And whether this transfers into a different experience for residents is also unclear and warrants future research. All right, so now moving to my third paper. This focused on the influence of specific CFIR constructs in assessing implementation efforts. So, recent literature speaking to the importance of constructs being present in sufficient valence and strength. Research questions for this paper included my first, does the valence and strength of constructs in the following three CFIR domains increase the number of MOUD types accepted? And I focused on the three domains circled here, so intervention characteristics, outer setting, and inner setting. And then my second research question, does the valence and strength of constructs in the same three CFIR domains increase the extent of MOUD use among residents? And I used the same three CFIR domains, and I predicted that RRs with more positive valence and strength in these domains would increase the number of MOUD types accepted and extent of use. So my dependent variables remained the same, my control variables remained the same. Independent variables for this paper were different. Just as a note, those that are in green were taken from previously developed and validated measures. Those in blue were developed by myself, starting with intervention characteristics, so beliefs about MOUD or perceptions of MOUD as an intervention. This was measured with 11 Likert scale items. 3 inner setting domain constructs were also assessed. Those were organizational culture, organizational climate, and organizational readiness to change, each of which were measured with the mean of Likert scale items. And then lastly, 4 outer setting factors were assessed, and these were measured by the responses of 4 questions. The reporting MOUD status to outside organization, next certification status, external funding, and then connection to an outside organization such as NERC. Okay, so this visual presents findings from the Poisson regression assessing the association of CFIR domains and constructs and total number of medications accepted. So 2 variables were significant, perceptions about MOUD as an intervention and then certification status. RR leaders that scored higher on the MOUD beliefs intervention scale reported accepting more types of MOUD. RR leaders from houses that were also certified reported accepting more types of MOUD. But I had a very wide confidence interval for this certification component, not shown on this graph. So, so I didn't show this on this graph because of the wide confidence interval. So the majority of houses were certified, meaning that replication with more non-certified houses is needed. And then this next visual presents findings from the OLS regression assessing the association between CFIR domains in construct and extent of MOUD use among residents. Again, I used beta values shown here to compare across variables and understand the magnitude of effect. 4 variables were significant. So 3 variables were significantly associated with increases in extent of use. Those were perceptions about MOUD as an intervention, organizational climate, and then bed number. And then conversely, 1 variable was associated with decreases in extent of use, and that was organizational readiness. So, in thinking about implications, starting with intervention characteristics, so this makes sense. Perceptions about MOUD as an effective intervention were identified in both models as a factor associated with acceptance and extent of use. overall negative perceptions towards MOUD have been cited as a challenge to implementation. What might be helpful moving forward is finding ways to increase education about MOUD to our leaders, as this webinar does, and finding from more so just like credible sources within maybe the recovery community, as well as finding ways to increase partnerships with MOUD providers in the community might be helpful strategies in improving views of MOUD among operators, and also just reducing this idea or concern around the complexity of implementation. In regard to outer setting, among both outcome variables, houses that were certified were associated with greater implementation. Because certification status had a really small effect size for increasing extent of MOUD use among residents compared to total number of medications accepted, future research is really needed to assess whether certification actually aids houses in integrating residents who use MOUD. And then future research is also needed to better understand this link between funding and NAR involvement. And then in regard to inner setting, organizational climate was significantly associated with extent of use, but not total number of medications accepted, meaning a supportive learning climate and climate of MOUD use was an important factor in increasing actual use among residents, but only with a few medications. So this might suggest the importance of our openness to MOUD as an intervention. Questions asked within the organizational climate construct were related to perception of RR's shared capacity for change and learning climate, including leadership openness to feedback, team members feeling valued, and opportunities for reflection and experimentation. So ongoing research is needed to better understand which aspects of an organizational climate support MOUD use, including the impact of staff feeling supported and integrating residents who use MOUD or leaders feeling supported, and efforts to reflect. Also, it would be important to look at efforts to reflect and evaluate implementation efforts, and then any internal incentives to implementation. And then lastly, surprisingly, readiness for implementation was significantly associated with a decrease in extent of use among residents, although marginal. And this was consistent across sensitivity analyses and subgroup analyses restricted to certified RRs. So this really contrasts with the intuitive idea that staff who feel well supported and have the necessary leadership and resources are more likely to implement. So one possible explanation that I thought of is readiness reflects perceived capacity rather than actual use. So for example, residences in high need areas may be using MOUD more, even with fewer resources, while better resourced residences may report higher readiness but have less demand. And then it's also possible that our measure of the readiness construct didn't fully capture MOUD specific readiness factors like access to prescribers or staff knowledge. And then there may also be a mismatch between feeling ready and having the actual opportunity to implement, especially if key external partnerships are missing. And then importantly, I didn't account for local OUD prevalence, so this might also explain this finding. Really quickly, my limitations are fully outlined in the papers, but in summary, my study is limited and that was cross-sectional, a convenience sample was used, and limitations existed related to my measurement approach. So to wrap up, overall implications across these papers, attitudes towards MOUD emerge as an important factor influencing implementation. Ideological beliefs about whether MOUD aligns with recovery philosophies can shape whether recovery residences are willing to allow or support residents using MOUD. So addressing stigma through education and training and exposure to evidence on MOUD effectiveness may help reduce these barriers and improve access to treatment. This also relates to addressing preferences for certain types of MOUD and better understand reasons for preferences, including whether this is related to stigma or logistical barriers. Another key implementation is the value of using implementation science frameworks such as the CFIR and guiding implementation. Findings suggest that factors like organizational climate, perceptions of MOUD effectiveness, and certification structures influence implementation. And the frameworks like CFIR can really help RRs systemically address these factors before attempting to implement MOUD. So using a structured framework may help organizations also anticipate barriers or leverage facilitators. In terms of policy, a major implication was that findings reveal a link between certification and implementation, highlighting the importance of sustained support and funding for NAR organizations. As mentioned in prior research, houses, they have expressed concerns about not having adequate financial resources and additional financial support. So linkages with NAR and grant support may be a solution to this, and leveraging certification as a tool mechanism also to support MOUD implementation. And then finally, in regards to research, this dissertation highlights the importance of identifying a theoretical framework and assessing factors impacting implementation. Future research should continue using the CFIR and the proposed research agenda outlined in my first paper. Also, refining my survey instrument or other survey instruments that assess CFIR domain and construct. Additionally, these findings emphasize the importance of continued research directed towards initiatives to decrease stigma, towards MOUD and specific types of MOUD, and then special attention should be given to specific populations also disproportionately impacted by MOUD preferences. And then lastly, ongoing research should continue to cast a wider net, investigating MOUD uptake in all types of RRs, including Oxford houses within all states, including those without well-developed NAR state affiliates. And lastly, research should assess the finding that I had related to readiness and reasons this was related to decrease in extent of use. All right, so that concludes my presentation. I have my contact information here, and I believe that's put in the chat. Here are my references. I'm happy to share that as well via email. And I think I'll stop sharing right now.
Thank you so much, Dr. Nichols. That was an excellent presentation. So at this point, we want to open up for questions. So audience members who have questions, you can raise your virtual hands or put questions into the chat. And I already see a hand up. Roland Lamb.
Yeah, thank you. Very good presentation, and I'd like to learn, a little bit more going forward. So I hope there's somewhere it's available to get your dissertation, be able to read it. I would, however, like to get your impressions of the impact of stigma on the various stages of the CFIR. Methadone, in particular, has been a victim of a long-standing, agenda or stigma when it comes to medication-assisted treatment. And when you have a construct such as the one that you're looking at, I'm wondering how much you were able to get a handle on the impact of stigma across all those segments. Thank you.
Yeah, yeah, absolutely agree. I mean, having worked in methadone, that's really what started this for me because I saw the impact of just the stigma specifically against methadone. Um, so I think, as I showed, like there are like in terms of the characteristics of the individual in the CFIR, there is really just a lot of preference for other medications. And then also, I didn't study this, but I imagine in terms of the intervention characteristics, CFIR domain, there's probably concern around whether methadone is effective. I mean, obviously that's not my thought. I know it's effective. I've seen it firsthand. But I imagine that, changing the perception of how effective methadone is as an intervention, but also, I didn't study this in my dissertation, but from my personal experience working in the field, um, I think there's just a lot of misconceptions around, if they're if someone is on methadone, are they in recovery? I mean, that's something that I think comes up a lot. And again, changing the stigma related to the perception of methadone and also the characteristics of the individual on the front lines, like what knowledge do they have of it? What experiences have they had with folks using methadone? How do we provide more education? How do we maybe change those perceptions? And then also, like relate to the inner setting, just like the overall culture of the recovery residence. Like, is the recovery residence somewhere that is accepting of methadone? Are there, previous experiences of folks working in the RR who don't like methadone? It sort of is all overlapping, I guess is what I'm getting at. Sorry for this roundabout answer, but I think primarily intervention characteristics of the individual and inner setting are all things that should be targeted and reducing the stigma related to methadone.
Great. Our next question from Paul Stevens. I think you had your hand raised.
I did, yeah. I have several, and I just posted a message. But I'm curious why you didn't choose to sample Oxford houses.
Yeah, so I tried. It was very hard to find public information available online about Oxford houses, and I actually reached out to leadership at houses, but because my survey wasn't developed, they were again like very positive experience in talking with them, but I think they had concerns because I didn't develop the survey with them, and they felt like it wouldn't necessarily fit with what Oxford houses, maybe how Oxford houses were the same or different. So I didn't get to include Oxford houses, unfortunately, but that was something I explored.
Okay, well, I just feel somewhat obliged to point out that all 4,300 Oxford houses accept all kinds of medication for opioid use disorder. So I worry when
Wonderful.
you leave them out of the sample, and then your policy implications are to recommend funding for certification of NAR and not to recommend funding for certification of Oxford houses. And this is a small question, but you made a distinction between sober houses and Oxford houses. I'm not sure I understand that. Maybe I don't understand your definition of a sober house. My understanding is that Oxford houses are just one particular model of sober house.
Fair. I mean, that makes a lot of sense. Yeah, sorry if I misspoke there, but yeah, that's totally fair. And I think related to your question about, I think like because I didn't use Oxford houses in the sample, my recommendations may not be related to them because I can't speak to that since they weren't in the survey, unfortunately.
Okay.
Thank you. We're going to move on to the next question. Ralph Fabrizio.
Yeah, hi, Ralph Fabrizio, Houses of Extra Measures in Houston, and we are the Houston housing provider for Project Homes, which is a UT Health study that is funded by HHSC to address the opioid crisis. There's like 15 houses around the state. We're the Houston provider, and we are MOUD only for OUD only, very, very specific. And I wanted to ask, and I've got some reasoning for that, as to whether or not you will be looking at outcomes and levels of housing. The differences between a level 1 Oxford house versus state licensed level 4s and the 2s and 3s that exist between there. I mean, I have some concerns around the fact that NAR requires certified residences to have a reasonable accommodation policy and to accept MOUD. I don't disagree with that policy. What I disagree with is that the provider is not required to have any training around that or to have any kind of a system set up around that. And my observation in doing what we do, we have level 3 homes that are very structured, organized. We do med times where we observe. We don't dispense, but we observe. We're finding a high degree of success with people on a variety of MOUD. And because of the availability of grant funding and the fact that NAR certification is becoming more popular, we've got a lot of more providers out there that are having to accept folks that are on MOUD, or it's becoming more popular. There's more people that are on MOUD that are looking for housing, and folks that are going into houses that where maybe the the perception and the acceptance of it and the negativity around it. There may be fewer of those, but somebody is there. But if they don't have a system set up around it to support the individual, that being either through the culture or through its structure and how it's monitored or observed, or whatever that looks like, my concern is that the same outcomes are going to occur when that individual went home and was able to either divert it or abuse it or stop taking it so they could go get high. Yeah. So I'm looking at what is there going to be anything on the back end of this possibly that's going to say, your level 2 houses have this measure of outcome when there was this much training and this much structure within the home involved. Level 3 houses have these outcomes for the different types of MOUD when there was a system in place and training and education involved.
Yeah.
So I kind of jumped around a little bit. I'm sorry, I got a lot of words.
No, it's so great. And I feel like I can't answer that. Unfortunately, I think that's like steps for future research is definitely looking at the outcomes. I won't be looking at that, but I think that's a great idea for researchers in this space. And I agree with you, without the necessary supports, it's not going to be a good fit. And part of that CFIR is talking about the process and planning for implementing MOUD and if the necessary supports are there. So it's a great point. And I've seen that too, when folks are using MOUD and they're not in a setting that's supportive of them, or even just in outpatient care, like it's just not going to work. So,
yeah, which that provider that was then forced to have that reasonable accommodation and take folks, and then they go, yeah, look, see, I knew it wasn't going to work, when they did nothing to support it working.
Mm-hmm. Yeah. Great point. I think we have time for just one short question. Joe Adams.
Hi, I just want to point out that the NAR standards do not include access to MOUD, which is why a couple of states, including Maryland now, and also New York and Florida, and I think some others, have passed either regulations or laws specifying, that the state certification requires access to MOUD. But you have to read the NAR standards carefully and just kind of look at the standards themselves, not the appendix or the other, verbiage which is there. And I believe from talking to people in Florida and New York that if there is an actual requirement, regulatory or legal, to refrain from limiting or prohibiting access to MOUD in a certified house, that changes the landscape. That I believe that probably, pretty dramatically increases the number of certified houses, especially, or maybe all houses, to refrain from prohibiting or limiting MOUD.
Okay. Thank you so much. Okay, I want to encourage everyone. We're running out of time. These are excellent points and questions. We really appreciate the questions you've asked of Dr. Nichols. If you have any further questions and like to contact her directly, please feel free to do so. I want to move us along and tell you about some upcoming events. So next month's webinar will feature Dr. Jennifer Miles, and the title of her presentation is MOUD Utilization Among Philadelphia Recovery Home Residents. And in June, we'll hear from Niles Zoski, and he will be presenting on tobacco use in recovery housing, determinants, policies, and opportunities for cessation implementation. So the I-STARR projects are held on the third Tuesday of the month from 11 to 12 for those on the West Coast, which is 2 to 3 for those on the East Coast. And you can register for any or all of the webinars on the, we've scheduled on the I-STARR website. You can also stay connected with the I-STARR project through our social media accounts, which are listed on this slide. And while you're on the website, you'll also see information about the I-STARR training series. And the training series consists of 12 webinars with separate training topics for recovery housing operators and providers, as well as those interested in conducting research on recovery residences. And those who participate in all 12 webinars in the training series will receive a certificate of completion and will be provided the option of being identified on the I-STARR website as someone who's completed this training. So at this point, because the live training series has ended, we can only track completion of the webinars if you register for the series and view the webinars on the I-STARR Learning Management System on the website. If you have any questions about the training series or about how to complete it, please reach out to us. Now we're running out of time. We thank you so much for being here with us, and we thank our excellent presenter, Dr. Cindy Nichols, for an amazing webinar, and for everyone in attendance for your time and attention. And we hope to see you back again on Tuesday, May 19th. Enjoy the rest of the day and intervening month. Thank you so much. Appreciate it. Bye-bye.